Hi, welcome. I'd like to introduce Dr. David Adelson, neurosurgeon from Barrow Neurological Institute at Phoenix. Welcome, Dr. Adelson.
Thank you. Well, it's wonderful to be here today. And again, I'd like to thank the group from Epilepsy Awareness Day to give me the opportunity to speak with you today. My goal is to give you a flavor of kind of where our thinking is with regards to surgical interventions and those kinds of things. And, you know, how do we think through certain problems and go from there. And then be happy to take questions at the end to go over that. So I'm going to start with here. I believe you can see my screen. I'm just going to minimize some other things. So anyway, I'm just going to jump right in. I do some work for Medtronic, so just a disclosure, but I'll keep things fairly generic during this talk so that that there's not any particular confusion. But anyway, with regards to the surgical treatment of epilepsy, it's been around a long time. It's actually the first epilepsy surgery was in the 19th century at the end of the 1800s. And, you know, early on, most of the surgeries were done in adults. And over time, we've clearly seen, you know, improvements in our outcomes. And, you know, as a result, you know, surgery has been considered, particularly in very severe situations. One of the things that we have to recognize, though, is that epilepsy is the most common neurologic disorder of childhood with an incidence of upwards of 2%. So we know that there are a large number of children that have epilepsy and suffer from epilepsy. And really it's surgery and intervention in such a, I guess in some ways, a radical way, really should be considered when medications fail. And I'll go over these in just a little bit. Really the key takeaway messages here for the day is that our best outcomes come when we have a really accurate localization of where that seizure network is arising. By doing so, really, when we start to talk about innovation, it's really the innovations that we've seen over the last 5, 10, 20 years have been such that we can improve our diagnostic accuracy so that we can target that seizure focus or that seizure network. With regards to surgical innovations, what we're doing in many ways is because we can now really start to target where those seizures are arising, we can then start to come up with surgical treatments that allow us to target those areas. And in doing so, we can do things more minimally invasively. This way we can improve outcomes because we've targeted the appropriate place, but now we can also lessen morbidity. And then lastly, some of the new techniques with regards to neuromodulation really have provided new opportunities for children and adults that really didn't previously exist. And when we have specific targets where neuromodulation can be applied, we're going to improve outcomes. And I'll go over a few of these examples today. Well, suffice it to say, I mean, this is the statistics, and these have held true through the years. The reality is that after someone is diagnosed with epilepsy and they have a first drug introduced, about 50% of those patients will become seizure-free with just this first drug. But as we add new drugs or different drugs, the seizure control gets less and less, such that by the third drug, we're really only getting about a 1 to 4% chance of making a patient seizure-free. So as you can see, when we add all these up, there's about a third of patients really are medically refractory and really do need to be considered for surgical intervention. Well, if we look at just the prevalence of epilepsy across the United States, it's about 1%. So we're talking about, if we think that there's about 3 million patients with epilepsy, that means that there's about 1 million patients, adults and children, who would be considered medically refractory. And each year, though, and despite the fact that they got me working hard, you know, the numbers of epilepsy surgeries nationally is only around 7 to 10,000. And so if you consider and you look at that number of 1 million, and if we were only doing at most 10,000 surgeries a year, the reality is that there's a substantial number of patients that are not receiving adequate treatment and that are not being considered for surgical intervention. And if we also then take this and say, wow, we have 150,000 new cases a year, well, we're not even coming close to keeping up with the new cases that arise. And as a result, many patients, the average duration of their refractory epilepsy by the time they come to surgery is upwards of 20 years. And many of you are quite aware of the impact that, that epilepsy has on vocation, on education, on quality of life, all of those different things. And so when we look at this significant number of patients that are inadequately treated, we really have to take a step back and try to figure out these issues. Well, we do know that, and this is a paper that's now 20 years old, but this was really groundbreaking in that this randomized controlled trial showed that having surgery in patients who were medically refractory for the right reasons did markedly better than patients who continued with medication trials. And the reality is that as well, the mortality from surgery was less than that of the medical group. So when you start to look at this type of data, we have to start to recognize that surgery does indeed have a place for the right reasons, for the right situations, for the right patients. Well, there are many different seizure types that we see, and the reality is in children, we're often dealing with a much more complex seizure disorder. It can be diffuse, there can be extratemporal, they can have dysplasias, those kinds of things, excuse me. But we also know that they can often have numerous seizures per day. And so when we start to think about goals of epilepsy intervention, our overall goal is to stop the seizures. It doesn't really matter whether it's through medicines, through diet, through alternative treatments, or through surgery. And so we need to really have this perspective that, you know, one seizure a day or one seizure a week or even one seizure a year may be too much for that particular patient, and that's what's considered medically intractable. But some of the other goals of our intervention is to prevent further brain injury or interference of normal brain function from those intractable seizures. And again, in targeting children, if we can get early and complete cessation of the seizures, then hopefully we can, allow for more normal neural development. So with epilepsy surgery, the best option is for those patients in which we can try to achieve a cure. And that is because we've been able to target a very localized area of seizures or a localized area, a seizure network, where we can go in and do resection and or be able to go in and modulate those different areas. We now consider any patient who's failed 2 to 3 medications to be medically refractory. These are guidelines that have been around now for over a decade. And so in those patients, they should be, that there should be further evaluation and workup in order to identify where the seizures are coming from and come up with a potentially better solution than ongoing seizures. Well, we know the best outcomes depend on the seizure types. Obviously, different seizure types are much more amenable to surgical intervention. It's important for us to be able to not just lateralize where the seizures are coming from, but also localize specifically where they may, their origin is. and we need to be able to focus on those areas in order to consider surgical treatments. And also we have to try to look for a pathologic substrate. So when we're dealing with lesional versus non-lesional, we know that the brain is not functioning appropriate in patients that have epilepsy, but clearly when we're able to visualize not just the anatomic abnormality, a lesion like a tumor or a dysplasia, but also the functional abnormalities, where those seizures are coming from, is really ultimately what's important. And so the reality is that epilepsy is a functional disorder, and so we need to be able to identify that focus. We need to be able to localize that network or that epileptogenic zone, and then we can apply our surgical treatments to those patients. Well, having said that, we know that there are a number of new technologies for focus localization. Obviously, I'm not going to cover all of them, but suffice it to say is really that our neuroimaging has really come on board in order for us to really better be able to identify where those seizures are arising from. So I'm just going to talk a little bit about neuroimaging. Typical MRI, you look at this MRI, you say, oh, well, there's not really anything wrong with that. Everything looks really normal. And then you can get other sequences, and now you can appreciate in the same patient that indeed there is an abnormality. With this different sequence, we can see it much better. We can look in different directions and see where that potential lesion or abnormality arises from. And then in those instances, now we can start to develop a hypothesis for where the seizures arise, where's the epilepsy coming from, and then potentially, where might we be able to start to think about targeting our treatments. Similarly, with increased technologies, we can now start to look at cortical dysplasias that are more subtle. So the one I just showed was not very subtle. It was quite obvious. But in other areas, what we're trying to do is look at abnormalities in the thickness of the gray matter to look in areas that we may have called those normal in the past, but now are percentage-wise different compared to normal controls. When we can do this, then we can start to target, and you can see these green dots were a series of electrodes on the surface of the brain. And what we were trying to match up was the anatomic abnormality, the cortical dysplasia, with the functional abnormality that we picked up on the grid. Well, similarly, we can do cortical tractography, and so we can also see where the fibers are within the brain, and then be able to start to see what might be safe corridors or areas that are particularly affected that we may go on to use as some of our maps when we create basically a brain GPS in order to do surgical planning. Well, as I mentioned, epilepsy is a functional disease, and so we need to use functional imaging in order to visualize the abnormality. There are a number of different modalities to do that. Many of you have heard of PET scanning or SPECT scanning. We use combinations now. With improved technologies, we can marry one on top of the other in order to try to match these up. Magnetoencephalography, or MEG, is also quite useful. And then now more recently, functional MRI and particularly resting state functional MRI have really come on the scene, particularly with regards to children, and I'll go over those in just a little bit. Here's a PET scan, and you can see clearly in this case when we're looking at cerebral metabolism, so we're looking at normal glucose utilization of the brain. This is an area where there was not normal glucose metabolism. This would then give us a clue that this is a dysfunctional area of the brain and an area that we might consider for surgery if our data is concordant and matches up to that abnormality. And as I said, we can marry these scans onto one another. So here's PET scan with the MRI. And so here you can see the metabolic abnormality. Well, this is also, if we look at with regards to the MRI, we can start to look for some subtle or other changes in this region that might indicate an underlying dysplasia or some other abnormality. Similarly with SPECT, this is another example. SPECT uses cerebral blood flow. PET uses metabolism. SPECT uses blood flow to look at differences of function within the brain. Here's a SPECT scan between seizures, and not very sensitive or specific for identifying the seizure focus. But if we do the ICTL scan, you can see the sensitivity and specificity go up. And that's when we inject the radionuclide at the time of the seizure. And then you can imagine if we take the ICTL SPECT and subtract the interictal SPECT, so looking at the rest of the normal brain, now all of a sudden we can start to look at a particularly targeted region that we might consider for intervention. And again, if we marry that SPECT, that subtraction study onto the MRI, now I've been given an anatomical map by which I can target potentially a surgical intervention. Well, again, there's a number of other types of information that we get from functional imaging. The first being function itself, and some of you may have heard of WADA testing. And so back in the day, and actually when I started, these were the types of approaches that were done in order to determine what was the function within the temporal lobe or in the parts of the brain that we were considering for surgical intervention. With the advent of functional MRI, now we're starting to look at supplanting the WADA. And in these instances, we need a cooperative, awake patient who can follow commands. And what we're looking for is that when we do a function, so if I'm talking to you or tapping my hands, what I'm doing is that I'm increasing the metabolism in my brain, and then my brain is then correspondingly increasing the cerebral blood flow to that area in order to provide enough oxygen and glucose and those kinds of things. But the reality is that doing this very complex test within the MRI scanner is very difficult or impossible to do, particularly in young children. And so for that reason, other solutions that we've looked for have had to sort of take that into consideration. But still, within the task-based functional MRI, we can see and identify areas of function juxtaposed to areas of abnormality, in this case, a tumor. And so now we can know where the function is versus where is the abnormality. And so now we can start to build up our hypotheses and our potential therapeutic plans for patients in these instances. Well, the resting state has now come on, and this is where I believe really new directions for children because they don't need to be awake. You can actually look at the resting state of the brain and look where there are normal networks, where we would expect normal networks to be. And then we can also then look at areas which look like abnormal networks and where those may be arising from, because they're not typical of what we would see across a population. And so there's been a lot of work in resting state over the last 5-10 years. And now we can start to pick out where there's normal functions. Here you can see all the different areas that have been explored, as well as language. And so we can now better understand where the normal language networks are, and then begin to start to see where abnormal networks arise. In this case, we are showing the abnormality in the left temporal lobe. You can appreciate that the network is quite different from the opposite side. And here's an area where we had some suspicion for abnormal electrical activity. Now we've confirmed it with an abnormal functional network. And so now we can have a direct hypothesis for the management of a patient like this? Well, we can also use the resting state and see where functional areas are, where the seizure focus is relative to lesions. So here in this patient with a low-grade tumor that we were planning on going in and resecting, now what we would be able to do is to approach this patient with, not only are we going to try to remove the tumor, but now we're also going to try to cure their epilepsy. Because there was many instances where we might remove the tumor, but patients still had seizures or epilepsy afterward. Well, this is a great opportunity for us to be able to treat both of the problems in one instant. So I've talked a little bit about diagnosis and particularly non-invasive diagnosis, but there are instances where we're not able to localize the seizures in such great pictures as I pointed out here. And so then we would move on to something like invasive monitoring. So I showed an example of that on that cortical mapping. But the reality is with regards to invasive monitoring, that does require surgery in order for us to implant the electrodes and place them in the areas that we suspect the seizures are arising from. We use invasive monitoring if we're unable to lateralize the seizures or localize that seizure focus. We use invasive monitoring if the data is not concordant. So if the EEG shows us frontal lobe and our imaging shows parietal lobe, well, how do we marry those two together? And so what we need to do is we place electrodes in order to try to tease those different areas out. With regards to eloquent areas of cortex, we can also use those electrodes in order to map out where the normal functions of the brain are. Well, there's a number of different methods, and I'm not going to go into all of them, but suffice it to say is that most often in kids, we use chronic methodology because in those instances, we have some time, we place the electrodes, we go back to the epilepsy monitoring unit, and we spend time to try to really study where the seizures arise and where the eloquent areas of cortex are within that particular patient. Well, I'm dating myself a little bit, and while these pictures are not exactly from my era, my first cases as a neurosurgery resident back in the day were placing depth electrodes where we used pneumoencephalograms and angiograms and tried to map out where the electrodes would be arising. We've come a long way since then, and you can see in this next case some of the technologies that we now use in order to target our epileptic foci. So here was a young man who on EEG had frontal seizures, but yet had this lesion in the parietal lobe. We used the MEG, and this seemed to localize to that parietal lobe area, but there was some other data that seemed to also indicate frontal. And so what do we do in that instance? Well, what we did is we placed electrodes in the brain, and you can see not only did we cover the areas of the frontal and parietal lobes, but there was also some indication of possibly coming from the contralateral side. And so we were able to target this area, and the seizures were indeed arising from this region, but rapidly spreading to the frontal lobe. And we were able to identify that on these stereo EEG electrodes. And so in this instance, we were able to do a very targeted lesion removal, and this patient did very well and remains seizure-free now about 4 or 5 years out. Well, in some instances, we don't have such a good target, and we might place a series of electrodes on both sides. You can see there's a big difference from my time in the day. We can now do 3D renderings and see exactly where all our electrodes are arising. We can take a look at the brain and look at the electrodes relative to the cortex and the different sulci and the different locations. We can look at advanced technologies in order to look at what are called high frequency oscillations. So basically areas that we previously didn't or know to look for in patients. And so now we can identify areas of high frequency oscillations, and in these instances, be able to target with these specific electrodes where this patient's seizures are arising. With that, with all of this type of information, we can then start to think about surgical interventions. And so there are a number of different treatment strategies. So again, dating myself, this is kind of the strategies that we had back in the 1980s when I started. You can appreciate this was the extent of our surgical armamentarium, and we had really good results. So in an early series of mine, we had upwards of 85+% of patients who were either seizure-free or at least had improved outcomes relative to their seizures. And also clearly that we had less mortality with this group of patients as compared to those that were continued to be medically treated. Well, in the 2020s, we've modified our technique. So I haven't done an anatomical hemispherectomy now in over 15 years. We were able to modify the technique to make it safer and to reduce the complication rate. We also became much more minimally invasive, and so now we can do laser ablations of areas with very targeted locations of their seizure foci. And as well, neuromodulation has come on the scene, which has really expanded our ability to treat particularly the very complex group of patients that really didn't qualify for a resective or a disconnective type procedure. So I'm going to talk a little bit about the minimally invasive approaches that we do now. These are the kind of new innovations that I was asked to present about here. Laser ablation has been around now for about 5 to 10 years plus. In these instances, we stereotactically or use a brain GPS in order to place a laser probe in a patient to the area where we're concerned. So if we've targeted that location, we can now put a laser probe in that location. We use the MRI scanner to read the temperatures. And so we can see in real time as we use the laser, as we heat it up, as well as create safety markers around those areas so that we don't damage surrounding tissue. We can go in and we can ablate and remove or disconnect a seizure focus for a particular patient. And it was started for use in hypothalamic hamartoma patients with gelastic seizures. Here's a great example of some of our technologies that have come to bear. This was a 14-year-old young woman who came to us in Phoenix from Hawaii. She'd been having seizures since 6 months of age and really had been tried on multiple medications, had had no impact, but was having 6 seizures per day. Her EEG did not particularly localize, but her imaging was really quite obvious. You can see here on the left, the hypothalamic hamartoma, and then on the right images, some very important structures relative to that hamartoma, her mammillary bodies, which are very important for memory function. Similarly, in this image, sagittal image, you can see the hypothalamic hamartoma on the left, the yellow arrow pointing at it. And then on the right, what we're seeing is the mammillary body to the connection that goes for our memory function. So again, this area right in front of the fornices is our memory functional area, is the hypothalamic hamartoma. We need to be able to target this area safely in order to treat this appropriately. Well, we did a resting state functional MRI in this patient, and we found that the network or the connections from the HH to the rest of the brain was basically going up and posteriorly and backwards on this patient. So we needed to target that area. Here you can see the laser probe actually in the brain. We were able to target the hypothalamic hamartoma, and particularly we planned lesioning along the top of the hamartoma and posteriorly. And you can see that here. The orange represents the areas that we ablated. In this particular patient, she's now 2 years out and is seizure-free. And when we repeated her resting state, she no longer had that abnormal network extending posteriorly. As we've gained experience and with new technologies, we can start to think about the use of laser ablation in other patient populations. Here was a 17-and-a-half-year-old patient who had febrile seizures at 8 months of age, subsequently developed medically intractable epilepsy. Everything seemed to point to his left medial temporal lobe. Here you can see on this, with this arrow, the area of abnormality in the hippocampus that was showed it to be small, to be shrunken, to be damaged. And so again, using the laser probe into this area, we were able to do a very nice ablation of the offending temporal lobe. Here you can see the damage maps. And then this is the MRI right after lesioning. You can see the extent of the edema that the ablation causes. It's the reason we treat them with steroids before and after the procedure. And then this is the further MRI with contrast, again showing the extent of treatment in this patient. And again, this is another patient who is now about 2 or 3 years out, who's also seizure-free. Well, it's not limited to these different areas, and as we've expanded our indications, we can start to look in areas where there were cortical dysplasias. Here again, a map showing some of the damage maps for this patient. Here's the post-op, post-ablation MRI, again showing the extent of the ablation for this patient with cortical dysplasia. We've been able to extend this to other indications. Here is a 6-year-old young boy with Lennox-Gastaut and atonic seizures. He'd been tried on multiple medications, ketogenic diet, vagal nerve stimulator, which really didn't change his seizure frequency. And the biggest issue for him was the atonic or drop seizures that he was suffering from. Well, in these instances, this would be a patient that we would recommend for a corpus callosotomy. Here would be the surgical view of the corpus callosum, just graphically shown on an MRI in order for us to see the front and the back of the corpus callosum under the microscope. Here is the direct imaging that you would see. Here's the corpus callosum, anterior being the front of the head, posteriorly the back of the head. And then after I completed the callosotomy, you can see the division of those tracts, which is dividing the two hemispheres from each other. Here I've left the ependema of the ventricles intact, really to cut down on the risk of hydrocephalus or fluid collections afterward. Well, in that patient that I showed you, in his case, he had a very amenable anatomy for his corpus callosum. It's fairly flat, and so it gives us opportunities to place the laser probes in these instances versus a very rounded corpus callosum. So in this instance, we did a series of laser ablations using, in his case, 3 probes. Here was the Genu, the front of the corpus callosum. Here was the body of the corpus callosum that we ablated. And then here was the splenium, the more posterior aspect of the corpus callosum, again, using our laser ablation technology. And then these are just the maps afterward, just showing the extent of the ablation, in this particular patient. And knock wood, he's about a year or so out and remains atonic, seizure-free. So again, he has Lennox-Gastaut, so he has other seizure types, but at least from the ones that were the most potentially dangerous, the drops, in any given instance, this patient is doing very, very well and was able to be discharged from the hospital the day after surgery, unlike the open procedures, which they often stay in the hospital for 3 to 5+ days. Well, moving on with the advances in our technologies, neuromodulation has really come on the scene over the last, I would say, 5 to 10 years, on top of VNS, which has already been around for close to 25 years. The biggest challenge in patients with epilepsy is that, unfortunately, sometimes we don't have a discrete seizure focus that we can remove or ablate or disconnect, or the seizure focus is in an eloquent area. So if it's in a motor area of the brain, well, we really can't take that out. Or if it involves both hippocampi, those are important for memory function. We can't take both of them out or take out one if the other is damaged, because in those instances, the neurologic consequences would be much too great. And so in those instances, neuromodulation would be recommended. Part of our challenge is that with our growth in our technologies and innovations, we have to look at the risk-benefit of the different modalities and whether we should jump to one versus should we do it in a stepwise manner. Those are some of the things that we're still figuring out, because these technologies are still very young and still new. And so we're still trying to define the best indications for these different situations. Well, as I mentioned earlier, there's a number of different neuromodulation devices, but at least for vagal nerve stimulation with over 25 years experience, we can comfortably say that greater than 50% of patients are going to get a greater than 50% improvement in their seizures. And you can see that this is sustained over time. And that's really what is so important to highlight here, is that a new medication only has a 1 to 4% chance of working. And yet you can see study after study after study, even out to 5 years or more, that indeed we're seeing a marked improvement in function, seizure control in this patient population. Well, with the advances of technology, we're now starting to place electrodes in different areas of the brain. So there's responsive neurostimulation, there's deep brain stimulation. Responsive neurostimulation is really focused on the cortex or in the really superficial parts of the brain, while deep brain stimulation is focused where we're placing electrodes in deeper structures within the brain, such as the thalamus. Well, deep brain stimulation has been around for a long time. It's been used for movement disorders. There's a lot of experience in this area. And now we're starting to see literature that supports its use for epilepsy. And so we know that we're not trying to cure epilepsy. What we're trying to, in these instances, if we're going to neuromodulation, is really to control the seizures. If we can control the seizures, these patients overall do better. And this is really the reasons that we would recommend these type of interventions for patients. We know that it's safer to undergo the surgery than to continue to have uncontrolled seizures just on medicines alone. Well, again, just to highlight the differences, you can see here, this is responsive neurostimulation. We place the electrodes either on the surface of the brain or in just sort of the superficial depths of the brain. The contrast to that is deep brain stimulation, where we're placing the electrodes deep in the brain, particularly into the thalamus. Here are the different structures in the thalamus for seizure control. Right now, we're very focused on the anterior nucleus of the thalamus for more frontal lobe and hippocampal abnormalities, where we have, let's say, bilateral hippocampal dysfunction with seizures. We use centromedian nucleus for patients that have a more broader area of abnormality, particularly, again, frontal or parietal. And then we would consider a more posterior targeted nucleus within the thalamus, the pulvinar, if there were issues more posteriorly for a particular patient. We know that RNS, while now early in the experience, has good outcomes. We still need to continue to do and understand better in these patients the best targeted location for these patients. Similarly, in targeting things like the centromedian nucleus, we are seeing marked improvements, particularly in patients that were not without any other options when it came to seizure control. This is just a great example of a patient that we did now about 2 years ago. This was a young woman who had encephalitis. She was frequently in status epilepticus. She was really unresponsive to medication and diet. She'd been tried on pretty much everything, including a vagal nerve stimulator, but really was not able to really identify a specific focus. She had both left and right onsets, which I'll show you in just a second, but also her resting state showed, really bilateral involvement. This was that patient that I showed a little earlier with the electrodes in place to identify possible targets. Here were the HFOs that I mentioned. Again, using advanced technologies, we were able to determine the location of her seizures on both sides, as well as it gave us some areas that we could target for possible electrode placement. In these instances, we identified frontal targets as well as amygdala target in her. So this was a case where we placed electrodes both deep in the brain. So this was an RNS-DBS hybrid. We placed an electrode in the centromedian nucleus on the left, since the majority of her seizures seemed to be arising from the left. But we also placed a right amygdala electrode in this patient. And now we can start to read where the seizures are coming from and provide stimuli in order to break that seizure focus from occurring. So in this particular patient, this has worked very well. The seizures are being identified and the stimulus is being given. And in those instances, she's doing really quite well and has much better control of her seizure syndrome. Well, lastly, I'm going to come somewhat full circle. If we've got accurate diagnosis and we've got ways to approach things more in a much more targeted way, clearly some of the innovations are going to be improving our surgical accuracy and our efficiency, and that's really where you're starting to see neurorobotics. There are a number of different robots that are now available in the marketplace. These robots don't do the surgery. The surgeon has to do the surgery. But what this does is it helps to localize and target at a sub-millimeter level the areas of particular concern. So with regards to our decision-making, we ended up going with the Stealth Auto Guide. We do a number of different techniques and different surgeries where we use the robot. What we're doing is really integrating this into our surgical operating room and in our surgical workflow. So in this instance, you can see here the surgical robot really targeting for us. In this one, this was the next generation, much smaller than those other robots that I pointed out. It's one of the reasons that we felt comfortable in using it here. We did start using it in January of 2020. We were actually the first in the United States to bring on this particular robot. We started with those SEEG electrodes. We've advanced to doing the laser ablations. We now use it in a number of different technologies. Here's that patient I showed you from Hawaii. Again, with the targeting using a small probe into a small lesion. The accuracy was pretty good. It was a little bit off on the, you can see on the anterior posterior, but this was less than 1 millimeter, and so we felt comfortable moving forward with the ablation in this instance. So in summary, I hope I've highlighted the importance by which we know that intractable epilepsy impacts mortality. It's worse than surgery, morbidity, and the quality of life for patients. Excuse me, clearly having medically intractable epilepsy worsens all of these different areas. And we also know that outcomes from surgery for the right patients, for the right reasons, at the right time, are better when compared to continued failed medical therapy. We know good outcomes lead to whole new lives, and I have a multitude of patients in which it's clearly changed their lives, the ability to get new jobs, to be able to get through school, to really enjoy a great quality of life. But again, for specific reasons, for specific patients. Clearly, our future advancements, I hope I've given you a taste of where our innovations have been. It's been in seizure localization and network identification, and then now in being able to take that information and apply it in a much more minimally invasive way so that we can provide treatments not just more safely, but also extend the ability for us to give treatments to patients that previously would not have been able to have anything done for their epilepsy syndrome. So with that, I just want to highlight the fact that we could not do this without a great team, and I'm very, very fortunate to work with an amazing group of people at Phoenix Children's Hospital, at our Barrow Neurological Institute, really who really highlight the multidisciplinary approach that's necessary for this type of program. So with that, I thank you, and happy to answer any questions. So I'm going to jump to the chat function, and let me see where it kind of starts about when I started. Okay, so right now we do use DBS to try to help reduce. So the question is there DBS help to reduce seizures after corpus callosotomy? So the answer is yes. So there are patients with, as I mentioned, Lennox-Gastaut, which are multiple seizure types. So we now use multiple surgical techniques in order to, again, stop the seizures. So if the callosotomy doesn't take care of, let's say, the generalized seizures, but stops the atonic seizures, we can still use DBS in order to treat the other types of seizures using DBS. Have we done that yet? No, not yet. But that's really because we've now switched over a lot of our corpus callosotomies using laser ablation. So we're still sort of assessing the efficacy of doing that through that technique. But those are patients, if they do well. And also with DBS, I should highlight that it's only really approved for adults. And so our DBS and our RNS patients, we're doing what is called off-label. So we have done DBS in a child as young as 6 years of age, but that was really in a child who just had horrible seizures, was having 30 a day as a result of an encephalitis afterward. And so, it was really in order to give them some hope. And actually in that patient, she has responded amazingly well. We've reduced her seizures by upwards of 80–90%. So we're very excited about that technology for the future. But again, this is early in our experience, and I hope in the coming years I will be able to give you some more data in that regard. I see that there's someone has their hand up, Mr. Ware.
Hey, thanks, Dr. Adelson. Yeah, I wanted to be polite and raise my hand. I wondered, you shared a slide earlier on the funnel as far as getting patients to surgery and the amount of time it takes, and how, despite how much work your team's doing, you're only getting 7,000 or 10,000 surgeries per year. What kind of opportunities are there to accelerate that time to getting patients to the right surgery, or to increase the throughput, or both? How do we get more patients to the right treatment?
You know, part of it is this. The reason that I give and I appreciate the invitation to talk is because it's really to raise awareness. Many patients, I think there's two blocks toward patients getting to surgical treatment. The first is the fear of brain surgery. That's why I've tried to highlight the fact that surgery is safer than continued medical therapy. I'll give you a great example. There was a patient that we placed SEG electrodes in January of 2020. We had a particular seizure focus identified in her. We had her scheduled for her DBS in March of 2020, and you kind of know what happened then. And so we delayed her surgery to April or May. We were still trying to figure it out. And a couple of weeks later, you know, she passed away at home from SUDEP. So, you know, clearly we know that surgery is safer in these instances, and we do lose patients because of their medical intractability, and particularly if there was a surgical option, you know, we would recommend it in those instances. I think that some of the throughput, if families were pushing and saying, you know, wow, we're really happy he's not having 30 seizures a day, but he's still having 5, that's still, you know, an 80% reduction, but 5 seizures a day is still really an unacceptable number. And so we need to change what our expectations are, and that's why I highlighted that our goals are to stop the seizures, if possible, stop them completely, and do the best that we can in those instances. And so that's why we do recommend families to pursue all their options, you know, as aggressively as possible, because with the brain in the child, it's developing rapidly, and we want to get to cure them, or at least reduce their seizures markedly in order to treat those situations. The other block is that is some of the neurologists, and so, you know, some of them are from the old school that surgery was a failure. By doing surgery, you were failing the patient. So I think that, you know, part of the reason to do education like this and these type of venues, as well as at, you know, national and international meetings, is to raise awareness of what the options are and what the indications are for intervention. I hope that answered your question.
Yeah, it does. You know, throughout today, I've heard the same kind of issues from several talks, that the science is showing surgery is often the best outcome, and there are literally millions of people who won't achieve any kind of seizure freedom without it. And it's, you know, it's frustrating as a clinical person to not be able to get those treatments to the right people. So that's what I'm focused on.
Agree. It's been a huge frustration, and I mean, it's better than it was. I mean, you know, the first year I was here in Phoenix, they felt like we were maxed out on surgeries, and we were doing 10 a year. You know, now we do 10 to 15 a month, and we still have a backlog of patients. I mean, I'm booking patients into February and March, and our limitation in our instances is technology, availability of EEG technologists and technology to keep up with the demand.
Got it. Okay, thank you very much.
You're welcome very much. Anybody else with any questions? Well, great. Well, Again, thank you all for being here. Really appreciate it. And, you know, as I said, if you have other questions or other concerns, you know, please feel free to reach out to me, Mr. Levy, and the whole team at Epilepsy Awareness Day group are really know where to find me. So anyway, you all have a great day.